Hello and welcome, our audience. Thank you for coming. We're going to get started in a sec here. Thank you to SAEM. Thank you to our audience on this Friday afternoon of SAEM. This is Novel Approaches to Research Fellowship Training, is how it is in the in the syllabus, but I put fellowship in parentheses because that's not the part we're entirely emphasizing. My name is Limkakeng. I'm from Duke University. I'm the Vice Chief of Research and our Research Fellowship Director. We have an illustrious panel here, and we're going to have them each introduce as they come up. But to start, just to set the stage a bit, there's a... So we all know that many of us may have an attitude after several years of training, much like Calvin in this cartoon that says, I don't want to go to school anymore, and we are certainly feeling like we've had enough training. But we also recognize that research can be hard, and this word cloud represents many of the things you have to learn and learn how to deal with to do research successfully. And to have a sustained career, grants are particularly important, and it can be challenging to obtain even for the most senior researchers. And so we know that research fellowships also are a pathway to develop the skills and other assets such as mentorship, an environment, a niche, and importantly, time, both in the sense of time in your calendar day, but also time in your career to develop skills. But we also know that many people, and increasingly, are not pursuing that path. Anecdotally, I know that there are many research fellowships just this year who have not filled, just for lack of applicants. And so this is an area where we need innovation, and we need to start meeting our more junior pipeline where they are, and start thinking about new ways and new pathways to allow people to develop research training skills. So we're going to hear from 3 different types of programs. One is a Global Health Research Fellowship. One is what I call a graduate and sort of embedded research fellowship. And the third is a integrated, comprehensive research residency pathway. The format is we're going to have sort of the program director give a brief overview of their program, followed by an exemplar person who was actually either currently in or has finished the fellowship, talking about what that fellowship pathway looked like in their own career. So I'm going to hand it off to Catherine Staten to talk about the Duke Emergency Medicine Global Health Pathway.
Good afternoon. Thank you for being here. So I'm Catherine Staten. I am Vice Chief of Faculty Development and the Emergency Medicine Director of our multidisciplinary, here comes the big words, Herbert Jurgen Center Global Health Residency and Fellowship Pathway. That is a mouthful. Therefore, we call it the Global Health Pathway. It is a multidisciplinary process where we have 2 directors, an EM director, and we have Nathan Thielman, who is our overall director of our pathway. The concept behind this is thinking about when we want to do global health requires a lot of time-intensive understanding of the location where we work. A lot of times that will require time on the ground, integration into the culture, understanding the clinical challenges and needs, and an understanding of how to do equitable, sustainable, and reliable, decolonized global health. To do that, we have to think about how to get the time on the ground and the support and training, a lot of times which needs to happen at a university at home, and to do that in a multidisciplinary way so you have inputs from your collaborators, both at Duke as well as on the ground, to come up with good questions to find that good, appropriate answers. Our pathway specifically focuses on mentorship, dual mentorship between emergency medicine and our multidisciplinary mentor, but also mentorship from our on-the-ground partners, and many times team-based mentorship. We get a Master's of Science in Global Health through the Global Health Institute. You have a research project or program that you develop, one or a myriad of questions depending on your time on the ground. You apply for a grant within weeks of coming and starting your fellowship, and then you're mentored through the process of making that research project happen. It is a packed 2-year agenda. Even if people already have a master's program, we say that it must still be a 2-year program because getting grants takes that time to learn how to do the process, to get the grants, to do the research processes. As soon as you hit the ground, we pretty much say hi and bye and send you to your site for 6 weeks to understand the challenges on the ground, to meet your partners, and to learn about a plan for which you'll do for the next 2 years. You then have the Masters of Science in Global Health, which usually is the next year, so 2 semesters of classes, followed by anywhere between 8 to 12 months of experiential learning to understand and use the tools that you've gained through the didactic portion of your curriculum. There are funded and unfunded options. Honestly, there's pretty much anything in between as well. If you already have a master's, if you don't have a master's, if you want a different kind of a master's, all of that can be decided upon based upon your individualized career development plan and goals. And understanding that the amount of time in country that is possible also depends upon success in grant writing. But at minimum, 6 months of the time of your second year is in country to be able to do the projects that's necessary to do. Returning home, then continuing with analysis, mentored by both mentors and your team, to be able to then finish and have an academic research career to support your global health interventions and processes. Our training program components can be broken down into courses, experiential learning, and career building opportunities. We start by writing grants early and often, didactic research experiences, and career planning literally from day one to understand what you want, how you want to do it, how we're going to get there, and what data you need to be able to fill and backfill the processes. The Masters in Global Health obviously has a lot of conceptual base classes and courses that might help build your repertoire of tools, while the experiential learning allows you to use those components that you would learn both through an on-site management process as well as mentoring processes as well. Finally, thinking about the career building through networking and other career building didactics is built in. So our history has been quite cool. We started with Erica Casey in about 2011 when I came. She's currently at University of Washington in Seattle. Dr. Krebs continues to be in global health. She was a global health fellow funded to do road traffic injury work and traumatic brain injury work in Rwanda. She then went on to her ultrasound fellowship at Penn and is now at Thomas Jefferson, working in CHUK in Rwanda, working on National Trauma Symposium and ultrasound in the setting of emergency care in Rwanda. Dr. Brian Meyer is an emergency medicine physician at Caroline Clinic in Virginia Tech, and he helps develop the global health curriculum for the School of Medicine. Dr. Sophie Galson, we have been able to retain her at Duke. She is active in the hypertension cardiovascular disease research in Moshi and at DGHI, our Global Health Institute affiliate. And then, of course, Julian, who I can introduce, but he will also introduce as he stands up. He is our most recently graduated fellow and stayed at Duke, as well as global health faculty. He's currently on a K-23, understanding the cardiovascular disease in Moshi and looking for implementation science solutions to the challenges and giving quality care, as well as a School of Medicine educator at Duke. So it's been an excellent progress in terms of getting to where we are and understanding how to support an academic global health experience and platform for doing global health through academics. And with that, I'd like to introduce Julian so he can tell a little bit about his experience.
Thanks, Catherine. I'll be brief. Thanks for being here. So Catherine kind of laid out for you the way the fellowship works, so I'm just going to speak briefly about my experience in the fellowship. I had a rather unusual path in that I did my residency elsewhere and came back to Duke as faculty, and first as just regular full-time clinical faculty. And pretty early on, I realized that this idea I had in my brain that I could dabble in global health research in my free time was not a realistic path, and that I needed, if I wanted to have global health be an important part of my life and my career, then I needed to get grants. And if I wanted to get grants, then I needed to have preliminary data. And if I needed good preliminary data, I needed protected time to obtain that. And so after being a faculty member at Duke, I applied for the fellowship, and demoted myself to fellow and spent 2 years doing the pathway that Dr. Staten just described to you. I had some unique advantages and disadvantages. My unique advantages was that I had previously lived in Tanzania for 2 years when I was a Duke medical student, so I already spoke Swahili and had some connections. And then I had some disadvantages in that I had a particular research interest, which was in underdiagnosis of acute coronary syndrome in sub-Saharan Africa, and there wasn't a specific mentor or person established working on that question. And so I had to kind of cobble together a mentorship team, and my primary 2 mentors were adult ID doctors, which is one really cool thing about the pathway that Dr. Staten mentioned, is that it's very interdisciplinary. You're not forced to, you can work with anyone who fits your needs. And so although these 2 adult ID doctors obviously are not experts in either emergency medicine or acute coronary syndrome, and were not conducting that kind of research, they were experts in conducting well-run clinical research abroad. And so they were wonderful mentors to me, and they helped guide me through the fellowship. And for me, the real advantage of the fellowship was having a whole year on site to conduct research and get preliminary data. And that preliminary data is what informed my K-23 career development application. I'm certain, without having data to say, this is a problem, we found this is what we think needs to happen, and this is the training, the additional training and implementation science that I need to get there, I don't think that we would have had a remotely competitive application. So yeah, I think that's all I have to say about my experience, and thanks for having me.
Thank you, Julian. And so I'll just keep us rolling along and describe the second program that we're going to talk about is our Duke Emergency Medicine's Graduate Research Fellowship. If anyone's familiar with how many academic surgery programs just operate their residencies in general, it is very familiar. And it's, our program is laid out as a research fellowship for residents. The residents are identified internally from our program after 2 years of doing standard residency. And they aren't pre-selected through the match or anything. These are just our residents. They take a year of time out during PGY, what would be their PGY 3 year. And the concept is that they're spending most of their time doing research, but they keep connected to the emergency department by still having a little bit of clinical time, which amounts to roughly a shift per week. And then, in the following year, they complete their residency. For context, Duke Emergency Medicine is a 3-year residency. So they complete the final year of their residency, but because they've had their ongoing, a little bit of participation in clinical training during PGY 3, they won't have to work as much as at PGY 4, and so they're able to continue to have some participation or completion of their research projects which they have set up during their PGY 3. And so this is exactly how most academic surgery programs do research for their residents and set people up for an academic career. And we borrowed from that. So just to describe a little more concretely, we envision that each fellow has both a primary mentor and the fellowship director, which is me. And the primary mentor is more like their content or methodology mentor, and you'll see some examples of that. And we really hoped that the resident spends this year, the fellow spends their year embedded in an existing research environment, traditionally called lab, but it doesn't, as you'll see, have to be a traditional basic science lab, although it may be that. And of course, the primary orientation of activity is about doing a research project for which they should be first author, of course. We have standardized across all of our fellows some academic skills development, so it includes a week-long academic fellows course, which is an interdisciplinary conference, so that fellows from all disciplines go to this conference, and it's generalized academic skills like manuscript and grant writing. And of course, SAEM Armed is another program that we have our fellows attend. But there's also a broad element of flexibility and individualized development. And I could give you several examples of how different fellows do that. Some some of the benefits and sort of how we view sort of the benefits of this design is that we can capture people earlier in the pipeline than a traditional postgraduate or post-residency fellowship. And so we're hoping to capture people who, before maybe they make that decision of whether they're going to do a fellowship at all or pursue a career in academics. They still maintain some clinical contact and training, so they're still part of the residency program. We have a great deal of flexibility, and as you'll see in the types of fellows we've had over the last 5 or 6 years, we're not tied to one specific area or one specific lab. And this sort of like graduated plan so that you really have 2 years to do a research project spread out over time. The fact that we only select internal candidates means that we have sort of a longer period of time for vetting appropriate candidates, and so it's, all our fellows are known to us. We've already seen and known that, for example, that they're not going to be struggling clinically as a physician. And then the last sort of just logistics part is that most of the funding has been internal, and particularly for the fellow's salary for that year where they're out. However, we have had 2 candidates, actually 3, who have obtained external funding to help support some of their time in the year, and that's something we continue to pursue. So you can see some examples of what people have spent their time researching or in, training in. So our first candidate, John Appensteiner, embedded in a lab doing basic science research on sterile inflammation and DAMPs. Our second fellow embedded in our sort of global health lab, such as it was, although it wasn't a literal physical space, studying data science in pursuit of cardiac arrest. Our third fellow, again, more to a traditional basic lab, doing animal work on TBI, but then also transitioned to doing more translational research in neurocritical care. You're going to hear from Mitchell Vaverka on how he has embedded in an engineering lab, and we have our other current fellow, Lauren Coxum, who's working with Julian, actually, in global health and implementation on ACS in Africa. So you can see there's a broad diversity of both research methods and topic areas. I'm going to hand it off to Mitch to give you an exemplar example.
Well, hello, I'm Mitchell Vaverka. I'm the current research fellow, as Dr. Limkakeng mentioned. So I'm just going to talk a little bit about my experience thus far. So the first, why research fellowship and why kind of engineering. So I just put these up here. These were 2 examples that really kind of sparked my interest. The first one on the left is this Heimlich valve, which I'm sure you've all seen before on chest tubes. I remember when I got to residency, I was talking to my program director, and he was mentioning basically this piece that if you don't put it in the right direction, rather than obviously allowing the air to escape, it can actually reverse it and suck the air back in and basically make a pneumothorax worse. And I was just blown away that some engineer came up with the idea of saying, like, look, we'll just make this thing, and we'll be able to figure it out. It'll be okay. And there's been cases of people dying. Just basically, their solution was to change the color. And so that really blew my mind, and I was just kind of wondering what engineers were thinking when they kind of came up with that. And the second example is actually when I'm in one of my courses, engineering courses, talking about how we image people and using CTs and whatnot. And one of the engineers that was there was like, well, it seems like it's really complicated to move all of the pieces around to do the imaging. Why don't we just rotate the patient instead? And I thought that was just really fascinating that, not being grounded in the clinical aspect of things, that they don't realize how complicated that would be. So really being inspired to be at the ground level and the design of how things are made for patients and physicians was really interesting to me. So that's kind of where I sparked the interest in the engineering side of things. And the second portion of that, so this is really like a dense slide, but it's just to show that the second portion is obviously the design. The first is design. The second is kind of testing that piece that you've kind of come up with and making sure that it works well in the clinical space. And this is an example of, it's called the 21 CFR Code of Regulations of how we test for things. So we come up with a med tech device and the standards that it has to follow in a clinical setting. is very complex. And there's kind of two different arms. One is basically getting cleared from the FDA, and really it's only like 15 patients that that it has to work on in order for it to get cleared in the United States, which kind of blows my mind. But then there's the second one, which is kind of the efficacy and running trials. And so being able to understand how to run a trial properly is really important, and understanding the complexity of how medtech is integrated into that really inspired me to do this fellowship and really work with engineers from the ground level all the way up to seeing it work in clinical practice. So that's kind of why I went into this fellowship. So what is my research specifically? I'll try to keep it high level because it's kind of nerdy. I know that some people find it that way. So obviously in sepsis, antibiotics and fluid resuscitation are really important, and I'm sure that we all know there's different methods to determining how much fluids we give, and right now the current 30 cc bolus isn't the best way, or some of the research has said that we could do better at that. And so if you look at some of the studies that are out, they're saying that microvascular resuscitation is the next step, and looking at the microvasculature. And so one of the imaging modalities that's out right now is called photoacoustic imaging, that is able to look at the microvessels. And it's only been applied currently in an ex vivo setting and mouse models. And so I'm really interested in taking this technology and transitioning it to in vivo in the clinical setting, and seeing if we can apply that in basically pointing our resuscitation efforts in septic patients. So these are a couple of the photos they're not mine, but they're done in the same lab that I'm in, but that's kind of my research area. So looking at my fellowship timeline and where I'm headed and where I've been, so normal PGY1 intern year, normal PGY2 year, so I got a pretty good clinical foundation to start with. During my second year, I applied for an R38 grant, which is an internal training grant, and I'll talk about that in a little bit. But that was good experience to be able to kind of write a grant proposal. My third year, which I'm in right now, I have protected research time, so I only work one shift a week, and the rest of it is spent on research. So I've been basically getting my background together, kind of getting ground level working in the lab that I'm in. I'm also getting my master's in biomedical engineering to get more of that basic science experience in the lab that I'm in now. And then I'm also doing in concurrent the SAEM armed course, so I can get better experience with research clinical methods and applying for grants. My fourth year, I'll be finishing up my master's program and continuing with working in the lab, but it'll be more of transitioning to animal testing, first in human trials. And then my last year, as Dr. Limkakeng mentioned, I'll actually be a reduced amount working clinically, but obviously finishing up those shifts so that I can get a good foundation for my clinical side of things. And I'm also working on getting a technician award, so there's actually from my grant, I'll be able to have somebody to continue to do my research even when I'm working clinically, which is really cool. So what is the R38? It's an internal grant. It's for a year and a half of research funding. I also get an extra $20K for research expenses. And then, as I kind of mentioned, you can do this research technician award, which I think is really cool, that even when I go back as a resident, I've gotten money that I can apply to have somebody continue to run my lab, which I think is really important. And then it's really cool as well. There's a K38 and a T32, which are both internal, that only the pool of R38 applicants can apply for. So it's a much smaller pool to kind of continue on my research. And so, what are some of the benefits of doing this integrated fellowship? Why not just do it afterwards? This is just how I see it anyway, that you get the dedicated time inside your residency. So I like that I had the first 2 years to kind of, get my feet underneath me from a clinical setting. Now I can really do my research, but I personally feel I kind of have a safety net when I come back. I still have like an attending helping me out because I feel a little rusty once a week, but I'm able to dedicate my time to my research. I get the expanded education, being able to get my master's, and then also have the armed course really kind of help me with that process. And then the opportunities for additional grants I think has been really exciting. And then I think one of the biggest things for me is reduction in burnout as well. I find myself very excited to kind of bounce back and forth between the two. If I'm going to my engineering research, I'm able to further medical care in the emergency department. And then once I come back to the emergency department once a week, I find I'm really excited to help take care of patients. Whereas during my second year, I could feel myself shift after shift after shift, maybe really not finding as passionate about patient care as I am now. So I think that's a really cool part of it. So that's my kind of experience, and I'll pass it off to Dr. Bernstein.
Good afternoon, folks. So our program is, I guess, a variant of the program at Duke we just heard about. I say we, I did this when I was at Yale. I'm at Dartmouth now, but we started this about 8 or 9 years ago at Yale, the YES program, as we call it, Yale Emergency Scholars. And this was or is an attempt to integrate fellowship training and research residency training into one sort of thematically coherent whole. The impetus for the program was this. We're a 4-year residency, and historically, the graduates of the Yale program after 4 years would either some would do a fellowship of some sort, usually clinically oriented. Some would go right into practice, either in community or academic practice. Very, very few people went on to get formal sort of traditionally rigorous research training, whether it would be something that would lead to a master's degree or something like that. And so we weren't actually graduating a lot of people who went on to become investigators. And again, this is back in the early 2010s now. And I realized at that time, in my role at that time in sort of research, leadership, and academic sort of development in the department, that actually put us at variance with other residencies and specialties at Yale. So obviously, these are all research-intensive institutions, and I felt that we were kind of a newish department at that time, became a department in 2009, that for us to achieve the kind of academic credibility and maturity that other programs at Yale had, we needed to step up our own game around research training. I also, again, wanted us to do this to contribute to our own specialty, of course, to growing the body of knowledge around acute care and emergency care. So, as I thought about this, I started to speak with other residency directors at Yale in specialties like neurology, psychiatry, internal medicine, surgery to a lesser extent, because those specialties have these short-track programs that you might have heard about, or maybe have friends or colleagues who do those, where the research training is embedded in the residency, but the residency remains its traditional length, whether it's 3 years or 4 years or something. So these people wind up doing actually less clinical time, and then they go into somebody's lab, typically for a year and a half or something, maybe on a T32. And I talked about that with our chair, Gail D'Onofrio, and our program director, Dave DellaGustina, and we agreed that, because EM is such a clinically focused, such a clinically intense specialty, we didn't really want to shortchange the clinical component of the training. So we decided to try to find a way to splice and integrate the fellowship training into the residency, but we agreed we would probably have to add a year total. So instead of 4 years, people would do 5 years, but that would still save you 1 year, so to speak, instead of doing a 6-year, 4+2 kind of program. So that was the sort of pedagogical, reasoning behind this. So the YES program, as we've come to call it, it's a 5-year program, and it does, like I said there, we initially designed it to lead to a master's in health science degree, which is Yale's version of an MS. You can earn the MHS, but we have had a number of people in the program, like Caitlin, who already came to us with additional training and didn't necessarily need to do all the coursework needed for that. So it's sort of optional now. We've had at least one MD PhD go through the program also, and he didn't really need to do it. But you can earn the MHS degree. We do cap this at no more than 2 residents per year. So, 5-year total program, we could have up to 10, YES residents at any one time when we're fully maxed out. That hasn't happened yet. I think we've had 6 or 7 or something in when we do this. It is a competitive application, and unlike the other programs, we actually do have a separate number in the NRMP. So when people apply to us, they can interview specifically for the YES program as well as our traditional residency, and when they make their rank list, they can rank us twice, you know, the YES and the 4-year program, however they see fit. And we also submit 2 rank lists to the NRMP, the YES list, which is fairly short, and then the residency list. And we can have the same names on both lists, and we generally do. So that's how that works. These are the sort of domains of scholarship that we focus on in the YES program. We haven't really had a strong bench presence in our department historically. We've had some applicants who were interested in traditional kind of wet lab work, and we can hook them up with other folks at Yale and other departments. It becomes a little trickier to think about how to integrate their lab time with their clinical duties. But so we tend to focus on these domains of scholarship in which we have great strength in our department, but also, of course, with other collaborators with whom we work. The coursework for the YES program comes from 3 different places. Yale does have, we are one of the sites for the National Clinician Scholars Program, as Duke is now. Actually, there are, I think, 6 sites around the country. So we're one of them, so we do, we have a very close relationship with them. We have a number of NCSP scholars on our faculty. So some of the basic training in stats and qualitative work and so forth comes from there. Yale has something called the Investigative Medicine Program, which is a program where you earn a PhD if you are already an MD. So it's not like the integrated MSTP program that you might do in med school. This is you're a physician, you've done your residency, maybe a fellowship or not, but now you decide you actually want to get a PhD in clinical investigation. So it's another typically 4-year commitment that you make, and they have their own menu of courses. We use some of that. That's tied in with the CTSA at Yale. And then we started some EM-specific training because we realized there were topics that emerge docs need to know about that really most other specialties don't. Like, you know, how do you enroll somebody in a trial who actually came in with a, you know, a sprained ankle or a stroke or something? They didn't come to see you to be treated for whatever, electively for some disease like cancer that you can put them in a trial for. So we stood up our own courses as well. And we covered the full menu of coursework that you might need to become a competitive investigator. The mentoring comes from a number of buckets within the department. Obviously, outside the department, we started regular research in progress seminars, and of course, we expect the scholars to do research during training. Our curriculum model is, again, it's a 4-year residency, so years 1 and 2, the YES residents do it the same as people in the traditional program. We may have some pull-out conferences or seminars, and this has sort of evolved a bit over the years, but their block curricula are identical. Things start to diverge in year 3. So the way we did this, the way we were able to integrate this is the elective time that you would get in any residency, we actually take that out and we replace it with the didactic, training that you're going to need to do. So 2 electives for the regular residents, and then a CIU is the psych ED and some simulation time, and that's replaced with some introductory training in stats and methods and lit review and starting some pilot work. So in year 3, the YES program starts to diverge, starts to look a little bit different. That continues in year 4, which is pretty intense. This is the year when people are taking the National Clinician Scholars Program courses, learning some other things, learning some statistical programming, seminars. We started an internal competitive award program in the department. This was prior to the pandemic, so people could get monies get pilot grants to start some early work, et cetera. At the end of year 4, you finish the residency, you graduate with your cohort. One thing we realized that the framing of this was important. It's not a 5-year residency. It's a 4-year residency with an additional year that you're a fellow. Technically, you're a fellow. So you are board prepared at the end of year 4. You stay on in year 5. You're actually working clinically as an attending. I mean, you're a fellow, So you're supervising residents in the ED. You're continuing your work, your scholarship. You take the grant writing course, typically to write a career development award. And the way we pay for this, because there are some costs associated with this. We have to pay some tuition to the school for the coursework. So we take a portion of the professional billing that you earn in year 5 as an attending, and we use that for the course to pay for your tuition. So it's basically budget neutral for us, other than the substantial in-kind faculty time that we put into the program, and it's pretty invisible to the candidate. It feels like you're not paying tuition in a way. So you earn a modest salary as a 5, but it's certainly a good bit better than you were earning as a 4. So that's the financial model for this. So I mentioned there's a separate NRMP number for the S program, but we also have another route, maybe not unlike what you do at Duke. If a resident who matches into the traditional program, the 4-year program, decides at some point in the first 2 years of training that they would like to be into the S program, we ask them to speak with program leadership, residency leadership. And, if it looks like it makes sense, if that's, the way they want to go, and they're otherwise performing at a very high caliber in the residency, and they have mentors and so forth, we'll bring them into the program. And actually, that's how Caitlin Rice came into the program as well. So these are minor details. This, again, the internal grants program that we started in the department, research and progress seminars. The program is now, will be led by Yula Wang, who's the vice chair for research at Yale. These are some, I think we've had, 8 or 9 people come through the program maybe? I lost count, I don't know. But these are some of them, some of the folks, and some of the awards they've won. Alex Yanka is going to Michigan to join the NCSP program himself. Caitlin will tell you about her experience. Adrian Haimovich is going to graduate and going to BI Deaconess as faculty. He's interested in artificial intelligence and machine learning. Dan Nogi just finished a Tox Fellowship at Emory. He's applying for faculty jobs now. David Yang just won a nice training grant here. That's it. That's what we've got. And let me hand it over to my colleague, Caitlin Rice.
All right. Hi, everyone. So I'm Caitlin Rice. I'm going to talk about my experience in the Yale Emergency Scholars Program. I'm actually graduating in a matter of weeks, and I'll be staying on at Yale as a junior faculty after my fellowship. So I'll talk a little bit about my journey with this. So why I chose to do a combined research fellowship and residency, I actually took a really circuitous route to medicine. I had a career prior to medical school in research and advocacy, and I knew I wanted to pursue a career in academic medicine. And the residency fellowship allowed me to reconnect with my previous public health work while I was still in training. And it also, knowing I was going to be at an institution for a solid 5 years, when thinking about what research projects to take on, I could have more ambition because I knew I had a longer timeline, and that allowed me to take on things that I wouldn't have been able to do in a 3 or 4 year residency. Oh, back, there we go. So I mentioned circuitous route. So since graduating in 2006, I've had various advocacy and research jobs. I worked as a community organizer in affordable housing for a while, and then I did some global health work doing HIV testing in Beijing. I ran an RCT in Ghana looking at sanitary products and school attendance, maternal neonatal tetanus in Senegal. And during that time, I also got an MPH from Columbia focusing on socio-medical sciences. I sometime in that tenure decided I would become a doctor, and I found myself at Brown. And I concentrated in disaster medicine, specifically in the ethics of resource allocation, which has become more relevant than I anticipated. I graduated from there in 2017 and found myself at Yale. I sort of returned to my roots and got back into sort of housing and homelessness, and I started a community-engaged research project focusing on patients experiencing homelessness. I graduated in 2001, and now I'm here in my fellowship year, so that's kind of been my journey. My research interests have kind of coalesced into these sort of 4 areas. So I've always had this longstanding interest in social determinants of health, and I'm specifically focusing on housing and material needs and ED utilization among patients experiencing homelessness. And then I weave in my experience with disaster medicine by using disasters, pandemics, and periods of crisis as natural experiments. And so I'm really interested in political epidemiology and how during these times of crisis we have these interventions and policies that otherwise wouldn't have political and social momentum behind them, and looking at health outcomes in those settings. And then I want to translate that research into policy and programming, both to sort of inform in each disaster response, like how we fold in health equity and knowing what worked previously, but also in whether or not these, funding these programs moving outside of times of crisis makes sense, having used those like causal models from previous. And then I'm also really committed to healthcare workforce diversity. I do some research on that, which I'll talk about, and also just a lot of advocacy, education, recruitment, and involvement in national organizations. So Dr. Bernstein just went through sort of what our curriculum goes through, so I don't think I need to dwell too much on this slide or how it works. And I'll just kind of talk about like how I used that timeline. It does sort of vary by candidate and what their needs are. As he mentioned, I already came in with a master's in public health, so I kind of had to choose your own adventure here. In the first 2 years, when you're kind of learning to become a doctor, that's most of what the focus was, but that's when I started establishing my mentor relationships. I became involved with AWEM and ADIEM and some other local organizations. I did have some publications and some presentations, but those weren't like the pressure or the emphasis. And that's when I transferred into the program in PGY3. As PGY3, I did do a biostatistics refresher course, and that's when I began my community engaged research project and identifying my stakeholders and building my community advisory board. I got out a couple of publications and presentations, and I started to explore the world of funding sources and understanding grants and sort of the currency of the realm. In PGY4, you have a little bit more time. I expanded my coursework to include community engaged research, health policy, specifically taking courses on political epidemiology. I continued my community advisory board for my CBPR project, and I applied to 2 grants. Full disclosure, I did not win either of them, and that's okay, win some, lose some. But it was low stakes because I was only a 4th-year resident, right? I wasn't faculty, nothing was on the line, and it was a really great learning experience to get those scores and to go through the whole process. Got more publications and presentations, and then graduated with my class. This year, I've continued courseworks in health services research methods. I took a grant writing course, wrote another grant, fingers crossed all around for me here. And then, of course, you know, in that first year out of residency, you have a lot of sort of nuts and bolts. So you got to take your boards, you have to apply for jobs. Those are all time-consuming, so those are other ways I used my time. So examples of the products of all this labor. For the community-engaged research on patients experiencing homelessness, one of the things we did is we designed a hotel pathway from the ED to hotels for patients experiencing homelessness who also had COVID. And we wrote that up not only as a process, but also as an educational model for teaching health equity for residents. I also did a case series looking at the relationship of heat-related morbidity and mortality to opioid use in the setting of heat waves and climate change. And I did that with Dr. Bernstein. and then I also did some work on medical school learning environments and burnout among sexual minoritized students, which just came out in JAMA Network Open last week. So. And now I'm sort of focusing my niche, and that's where I am. This past year, it's been, I'm looking at sort of, again, these like sort of causal models, quasi-experimental models, so looking at COVID visitation restrictions and how those affected screening for interpersonal violence in the ED. And actually, Becca Hoffman's presenting on that at like 1:30, right? So a little plug for her, go to her talk. And quasi-experimental analyses of these health outcomes in response to housing programs and other social determinants of ED utilization. So yeah, that was kind of like the journey and what I did with that time. I think the benefits for this were really, it comes in the protected time. It allowed me, when I was on my job search, fresh out of residency this past fall, I had so many more deliverables. I'd written some grants, I had more articles, more presentations than I would have had in a 3 or 4 year residency because I had that 3rd and 4th year time to develop myself. That extended timeline, having that 5 years, like community engaged research moves at a glacial pace. And knowing that you have 5 years to invest in that, because that payoff is going to be years down the road. And I believe in community engaged research, and I'm a big advocate, so it also allowed me to build time and partnerships in the place where I'm staying that are going to be fruitful moving forward. I also just gained exposure and experience with academic medicine. You know, being able to like cut my teeth on grant proposals with low stakes environments were really valuable. And now I'm in the real game, so I'm glad I went through it. And I'll also echo what was said earlier about burnout. Being able to have something that you come home to and connect with, your passion during training, it really is fuel to move forward. Anyway, thanks for listening.
Certainly entertain any questions. I'll just remind the panelists they're recording this, so if a question's addressed to you, please speak into the microphone. And any audience questions or Joao? So the question, just to, for the recording, was these are all embedded, or these are, particularly the last two, are embedded in residency fellowship, and is there any commitment from the institutions for a traditional post-residency fellowship? And what you guys want to address? I think it's on. You checked. I think it's on or no?
So, commitment for a post-res. You guys think about
A traditional post-residency fellowship. Is there any sort of formal commitment to scholars, for example?
Yes. So yeah. In fact, we've had graduates of the YES program go on to do post-YES fellowships. I mean, Caitlin's staying on as a K-12 scholar at Yale. Oh, sorry. All right. Strike that from the record. We have. Dan Nogi did toxicology at CDC. I think Kamovich is going to be on a T-32.
I'm not sure about that.
I think the guy going to BI Deaconess is going to be on a T-32. And Alex Yanka is going to do the NCSP program at Michigan. So yeah, that's possible. We've had these sort of discussions about whether you really need to do another fellowship after putting in 5 years for this, and I think it's really candidate dependent. And if they need, they're not going to need to learn how to do a T-test, but if they feel they need additional content expertise around some domain of science, or they need more advanced analytic methods, I think that's appropriate. Alex is a good example. He's not going to take some of the standard NCSP, basic stats courses. He's going to learn some more advanced modeling, and that's what we encourage them to pursue.
We, for our program, have an example of a fellow, Kami Raja, did fellowship and then is now doing a critical care fellowship for 2 additional years. And, as part of that conversation, there was a realization, if you look at other specialties, the time from when they complete medical school to generally competing for NIH, even initial NIH grants, is generally by design programmatically 6 years. And so when you talk to a lot of emergency medicine residents saying, oh wow, I already did 4 years of residency, and you look at the specialty and how competitive we are compared to other specialties, I think we have to think about that, right? It takes time, as Caitlin pointed out. And so we're having that conversation right now, like, is this enough? And do we need further time? And maybe we need to normalize, like, think about that, guys. Every internal medicine doctor most subspecialty internal medicine doctors competing for NIH grants are doing so 6 years after they got their terminal degree. And there's probably a reason they're more successful.
I actually have a question on your question, because the way that you asked it, it almost made me think about, like, you're using the example of Tanzania, so it's like the opposite of brain drain.
Microphone.
Right? So my question, to your question, is it the institutional retention of the learner, which is what you're asking about? Okay. So I think my understanding of the question now is there any institutional commitment to the learner to stay, or from the learner to the institution to stay? Because he was referring to D43s in other countries where they make it a commitment to the institution where they train. I think it's a different setting in Tanzania because there is so much brain drain. There are many times, I would say many of our institutions do not anticipate or know the job openings they will have 2.5 years down the road. But we do know that the more we train brilliant research minds, the more we will grow our research programs to be able to maintain sort of each individual programs. I think very occasionally we know which direction we're going, and we'll be able to say, we might have a position for you at the end of the spot, but I don't think that is always the case because of funding and processes. But if things grow together, then I think it's in that way. I think it's the reverse as well. I don't think that many of the learners have also given I will stay on for a certain number of years because there is, I wouldn't say an abundance, but I would say that there is more than there is in Tanzania in terms of other quality researchers that might be interested in the topics that we research. That answers your question. Other thoughts on that?
Yeah. So one thing I would also add, maybe slightly related, so we don't have a formal commitment to our fellows, and part of one function of all fellowships is a sort of vetting for fit. And just like we don't have a commitment to any of our residents that they're going to have a position when they finish our residency, and that would actually be frankly unsustainable anyway. I think one goal of any educational program is to disseminate your trainees, your graduates, to have broader impact beyond the walls of your institution as well. And in another dimension, maybe another digression is that, we had a research fellow who's not actively engaged in academics right now, and I think a fellowship and a training program is a time to try something on, and sometimes it doesn't fit, and that's okay, right? It's an educational program, and so sometimes what you learn is that this career is not for me, and so. I think it's better for someone to learn that in a fellowship program than to find themselves in their adult job and then burn out or whatever. So perhaps that's also a form of success that isn't traditionally tracked. So I think we are at the end of our time formally in the room. Of course, we can continue this conversation elsewhere, and thank you for attending, and welcome any sidebar conversations. Thank you.